Hello, my name is Dr. Ismael Elhalaby. I'm from Tata University in Egypt. Today I'll be presenting our study, a randomized comparative study regarding the thoracoscopic T2 and T3 sympathectomy versus T4 sympathectomy for primary pulmonary hyperhidrosis in children and adolescents. It's well known that hyperhidrosis is an excessive perspiration beyond the physiological needs, and when it's present in significant amounts in the palms and axilla, it can cause significant psychological, social, and occupational inconvenience. Regarding the level of sympathectomy, there has always been a controversy regarding the proper level, and it was found that both T2, T3, and T4 sympathectomy, all of them, they can produce resolution of the pulmonary symptoms. However, they differ in the post-operative results, the patient satisfaction. From here, we aimed to do this study to compare the safety and efficacy of T2 and T3 versus T4 in the measurement of primary pulmonary hyperhidrosis in children and adolescents. And the study included 32 patients, which were randomized into two groups. The first group included 18 patients and the second 14 patients. We tended to do the operation sequentially, where we operate on one side first on the dominant hand, and then we operate on the other hand a few months later on. Group 1 included the 18 patients, as we said. 14 of them underwent bilateral sympathectomy, and 4 of them underwent unilateral, only on one side. And the group 2 included 14 patients. 11 of them underwent bilateral sympathectomy, and only 3 underwent sympathectomy on one side. Age distribution was comparable in both groups. It ranged from 5 years up to 18 years of old, almost equal also sex distribution. Patients were asked initially to rate their quality of life with living with hyperhidrosis ranging from 1 to 5, where 1 is very poor and 5 is excellent. And as you can see here in the results, the majority of patients mentioned that they are having very poor quality of life living with hyperhidrosis. We tended to do the surgical technique or the surgical procedure in a semi-fowler position, where the patient had his back elevated to the other side. We had placed the pores at the fifth intercostal space mid-axillary line, and for the camera, and the working port was in the fourth intercostal space anterior axillary line. Out of the 32 patients, as we have mentioned previously, 7 of them had underwent the procedure only on one side. Because 5 of them were satisfied with the primary surgery, they weren't very eager to go having the procedure on the other side, and 2 patients lost follow-up after 3 months. No compensated sweating was noticed in any of these patients. From this statistics, we can find that the operative time was almost comparable in both groups. Both of operations were feasible and safe, and there was no intraoperative complications. Regarding the postoperative outcome, postoperative dryness, over dryness, was noticed in 5 patients in the group 1, and it wasn't noticed in any of the patients in group 2. Compensated sweating was present slightly higher in group 1. Horner syndrome occurred temporarily in group 1 in 1 patient. Again, patients were asked to rate the quality of life after the operation in their follow-up visits, and there was a dramatic change in their quality of life score, where 25 patients rated to have excellent quality of life, 5 patients rated very good, and 2 patients lost follow-up after 3 months. Then a second questionnaire was taken by the patient 3 months post-operatively. As you can see here, where in comparison to the pre-operative evaluation, according to the questionnaire that we have made, you can see the difference in the results, where none of the patients rated good in group 1, and then 12 patients post-operatively rated their quality of life to be good, according to a questionnaire. Also in group 2, all the patients scored for good. 13 patients scored for good, unlike the scores that they have been scoring before the operation. So we would like to summarize that both T2, T3, and T4 sympathectomy, they are safe and effective treatments. However, post-operative compensatory hyperhidrosis seems to be more common with the T2, T3 sympathectomy compared to the bilateral T4, although we didn't have statistical difference between the two groups. And also the compensatory hyperhidrosis wasn't evident in any of the patients who underwent unilateral sympathectomy. However, this number is still in a small subgroup of patients and needs further study to clarify this data. Handover dryness occurs in a significant higher proportion in the patients with group 2, in the first group T2 and T3 sympathectomy. Mild moistureness of the hand occurred more commonly in T4 group, and this wasn't found in any of the patients who had T2, T3 group. In the majority of cases, this was very well tolerated by the patients, unlike the patients who had over dryness, where it was a little bit distressing for them. So we would like to conclude that due to the proven efficacy of both approaches and less frequent postoperative complication and more patient satisfaction in patients in group 2, we recommend T4 sympathectomy to be preferred than T2 and T3 thoracoscopic sympathectomy. Thank you very much, and I would like to thank the team of the Cincinnati Children's Medical Hospital for their support and for giving us the opportunity to present our study. Thank you very much.